All right, hi everybody. Welcome to our presentation. Today we'll be going over the 1990s. So first we're going to start off with what is happening in the world from 1990 to 2000. So the overall trend that is happening in the 1990s is ethnic conflict. One example is the Persian Gulf War or Operation Desert Storm, with Iraq invading Kuwait and the involvement of the US. Another example is the Rwandan genocide, which is an ethnic conflict between two ethnic groups in Rwanda. On the next slide, we have the Bosnia War, which is another ethnic conflict between among the 6 ethnic groups that make up Yugoslavia. And in the 1990s, we also have the ending of apartheid in South Africa, along with Nelson Mandela becoming president of South Africa. Drugs was also a large concern in the 1990s, specifically opioid epidemic, which is a pain medication. The increase in prescribing opioid was due to the pharmaceutical companies reassuring that patients would not become addicted. AIDS was another hot topic in the 1990s. In late 1990s, AIDS became the world's 4th leading cause of death, and the CARE Act was passed. And overall, we are moving towards ending stigma of HIV, along with enforcing laws that prevent discrimination. In terms of technology, one of the biggest advancements in the 1990s was the creation of the internet, which allowed for exchange of opinions and information at a rapid rate. So next, we will be discussing some acts that have been passed in the 1990s. So starting in the 1990s, we have Americans with Disability Act, which prevents discrimination against those with disabilities. In 1996, we have Health Insurance Portability and Accountability Act, which we now know as HIPAA, which protects health information from being disclosed without the consent of the patient. In 1997, we have Individuals with Disabilities Education Act, which is providing free education to children with disabilities and special education services. In 1997, we have the Balanced Budget Act, which created caps on Medicare Part B outpatient rehabilitation services and extended prospective payment system to cover home health beginning in 2000. We also have skilled nursing facilities beginning in 1999 and inpatient rehabilitation units beginning in 2006. Lastly, we have the Olmstead decision by Supreme Court, which states that states must place people with disabilities in community settings rather than institutions if appropriate. I will be handing it off to Maddie to talk about conditions being treated in the 1990s.
I will be discussing what was going on in the field of occupational therapy in the 1990s. I will begin by discussing the conditions most commonly treated by occupational therapists during this decade. The AOTA membership survey from 1990 described the conditions most commonly treated by occupational therapists. The most common condition being treated was strokes and hemiplegia. 27.1% of therapists reported treating a patient with these conditions. 12.9% of therapists worked with clients who had developmental delays, 9.7% worked with individuals with cerebral palsy, 9.5% worked with patients who had hand injuries, and 7% worked with individuals who had learning disabilities. A major change that was occurring around this time was the shift away from mental health. 83.4% of diagnoses treated were related to physical disabilities, and only 16.6% were related to mental health. Next, I will go over different modalities used in therapy. Some of the modalities used according to Pedretti and Pasquinelli include exercise, facilitation and inhibition techniques, positioning, splinting, sensory stimulation, and lastly, physical modalities, which are controversial. Facilitation is an increase in muscle activity, and some facilitation techniques include icing, fast brushing, tapping, stroking, and quick stretch. Inhibition techniques do the opposite and decrease muscle activity. Examples of inhibition techniques include deep pressure, slow rolling, and slow rocking. Positioning is used to help prevent contractures, unwanted reflexes, can reduce pain and stiffness, and can enhance focus. Physical modalities were used a lot in hand therapy, which was very popular in the 90s, as will be discussed later. Some believed OT should not use physical modalities, and in 1991, the Representative Assembly adopted a position paper on the use of physical agent modalities. Resolutions to rescind or modify the use of physical agent modalities were rejected because hand therapists were already using them as they were permitted by the state. This remains a controversial topic throughout the 1990s. I will be going over the theoretical approaches, and our other video on theories will go in depth on the specific theories. Some major ideas from theories in the 90s include the shift from a deficit model to a capacity model of service provision. Instead of examining clients based on deficits, chronic disease, and disability, OTs focus on lifetime programming based on professional knowledge to allow clients to live independently in a community and enhance their quality of life. In the 1990 membership survey by AOTA, more than 50% of therapists considered themselves to be specialists. The main areas of specialty were schools and hand therapy, and in the 90s, there were specialty certification programs for pediatrics and neurorehabilitation. The interest in school-based occupational therapy can be seen in the literature of the archives of the American Journal for Occupational Therapy. The first articles about school-based practice were in the 80s, and there was a large jump in publications on this topic in the 90s due to the growing interest. I will now go over some of the issues faced by the profession in the 90s. One issue faced by occupational therapists was economic decline, as health and education costs rose, but there was less access to money for health and education. Additionally, there were cuts in post-secondary education and K-12 education. More people were uninsured, and there were fewer managed health programs, federal and state reimbursements, and private industry programs. Additionally, due to Resolution J, which I will talk about momentarily, fewer students were entering the healthcare programs. In the 1990s, there were changes to the education requirements to become an occupational therapist. Resolution J was adopted in 1999, which required a post-baccalaureate level of education to become an occupational therapist, though this was not implemented until 2007. There were also changes to the accreditation process in the 1990s. The Accreditation Council for Occupational Therapy Education was founded in 1994, and a third step was added to the accreditation process. Schools were now required to submit a program development plan, which was not previously required. In 1996, the National Board for Certification in Occupational Therapy was formed. In the 1990s, occupational therapy faced an identity crisis based on the definition of purposeful activities. There were 7 definitions of occupational therapy between the years 1990 and 1999, and only 2 of these definitions did not address purposeful activities. Purposeful activities were important to occupational therapy. However, they are hard to explain. How can one tell what is purposeful, and what if an individual is unable to communicate what is purposeful to them? This made it difficult to explain what occupational therapy is when what constitutes a purposeful activity, an important component of occupational therapy, was unknown. Please click on the next video to learn about the theories of the 1990s.